Welcome, everybody. Welcome to the last session of Scientific Symposium of the ICCN 2024. I'm Ping Han Wong from Hong Kong. I'm co-chairing this session with Professor Yang Li from Beijing. We are very glad to have three distinctive speakers for this KDIGO-IACN Joint Symposium on Diabetic Kidney Disease.
All right, it's my great pleasure to introduce our next speaker, Dr. Meg Jardine, the director of the University of Sydney NHMRC Clinical Trial Center and a practicing clinician at Concord Repatriation Hospital. She has been influential in expanding the awareness and use of innovative and cost-effective methodologies to increase the generation of high-quality evidence. And her research focuses on investigating the progression and complications of non-communicable disease through randomized trials and epidemiology analysis, particularly kidney disease and diabetes, through randomized trials and epidemiology analysis. She has authored more than 240 publications with more than 15,000 citations, and she's a current executive committee member of the IACN and the chair of the IACN late-breaking clinical trials decision markers from 2014 to 24 to 2026. So there's a long list of the board member or committee member she's serving right now. And today, Dr. Jardine will give us a talk on the benefits of SGLT2 inhibitor and GLP-1 receptor agonist. One is not like the other. Let's welcome. Yeah.
Thank you so much, and thank you to Dr. Lee and to the organising committee for inviting me. It's a great pleasure to be back in Hong Kong, particularly on the 45th anniversary. So firstly, my disclosures, and the most pertinent are that I have been an advisor or on the steering committee for companies that make SGLT2 inhibitors and GLP-1 receptor agonists. So what we'll be talking about today is the similarities and the differences between the SGLT2 inhibitors and the GLP-1 receptor agonists. And I think the purpose of this is to help us all think about when we would use one, when we would use another, and is there a role for combination therapy. I'd like to thank KDIGO also for sponsoring this session. KDIGO has produced many guidelines and in fact has been very busy in the last few years as more and more treatments come through. So they had a diabetic kidney disease guideline in 2020, and then that reflected the SGLT2 inhibitors, and then that needed to be updated in 2022. And I think we're all expecting another update as they include the results of the flow data. But in the guideline that we had then, the key pillars were all mentioned in the treatment of people with diabetes and kidney disease. And foundational components there include the SGLT2 inhibitors and RAS blockade, with GLP-1 receptor agonists as a second-line therapy for those particularly at high cardiovascular risk. So I'd like to start off talking about the GLP-1 receptor agonists, and many of this will be familiar from previous talks, but I think it's important to reinforce the exciting messages that we have, and I'd like to think a little bit about some of the implications. So back to basics, GLP-1 synthesis and receptor expression. GLP-1 is synthesised in the hindbrain, and that maybe have something to do with drives for eating, but perhaps also some addiction behaviours. There's been some interesting observational reports that addiction behaviours improve on GLP-1 receptor agonists. It's produced in the alpha cells of the pancreas and in some of the L cells of the gut. The receptors are distributed around the body in many more sites, including the endothelium in particular. And so this underscores perhaps some of the modalities by which, some of the mechanisms by which the agents might be beneficial. There appears to be a protection of vascular endothelium, and that might be very important for the kidney. There's a reduction in oxidative stress, a reduction in local inflammatory markers. Inflammation is one of the really big stories that's coming through in many aspects of kidney disease lately. But all of these things may be part of what contributes to the reductions of albuminuria that we see and of glomerular sclerosis. These are some of the direct effects, the postulated direct effects, but of course, in addition, they're the indirect effects. There's a reductions in systemic blood pressure, in weight, in A1C, in sodium delivery to the nephron, and all of these may be mechanisms of protection. So we've known for some time that the GLP-1 receptor agonists reduce albuminuria, but we didn't have evidence for hard kidney endpoints until the FLOW trial, which was designed as a dedicated kidney disease trial. It recruited 3,500 patients who were all adults with type 2 diabetes and chronic kidney disease, all of whom were treated with background RAS blockade as tolerated. They were a high kidney risk population. They had a GFR of 50 to 75 and high levels of albuminuria, or a GFR of 25 to 50 with mid to high range levels of albuminuria. And they all received weekly semaglutide, 1 milligram subcut weekly. Now, it's important to think, to remember that all this data we're about to see is with this diabetic dosing of 1 milligram per week. Well, we've also seen the large obesity trials, which dose people at 2.4 milligrams, and they're the trials where you can see reductions of up to a quarter of people's body weight. Today, we're not talking about that, we're talking about the diabetic kidney disease dose, diabetes dose. And the primary outcomes here were the conventional kidney disease events based on a 50% reduction of GFR or reaching kidney failure or death from kidney or cardiovascular disease. So the population was a high-risk population. They were a mean age of 66. Most were male. That's something we all need to think about addressing as we recruit into trials because of the importance of being able to see if there's any sex-based differences in treatments. They were high risk in terms of their diabetes. Nearly 60% of them had had diabetes for 15 years or more. Around 1/5 had a prior history of MI or stroke, and again about 1/5 had a history of heart failure. Their diabetes was relatively well controlled. They had a mean HbA1c of 7.8% and body weight of around 90 kilos. They were at high kidney risk, which was by design. The mean eGFR was 47 mils per minute, and most patients, around 80%, had a GFR of less than 60. And they predominantly had high levels of albuminuria. And these are the results that we've seen already today. In this population, this high-risk population, there was a reduction in the composite kidney endpoint of 24%, and that was apparent relatively early in the study. When we look at the subgroups, overall, there appears to be consistent effects, but I'll pull out a few that are of importance. When we look at diabetes duration, the people at highest risk, those with the longest history of diabetes, certainly had at least a strong benefit, and that was bordering on significance for higher benefit in those at highest risk. I'd like to particularly focus on the regions because it's always important to look to see the effects in different regions. Now, the analysis wasn't powered for the subgroup analyses, but it did appear that the benefit in Asia excuse me, was stronger than seen in North America, but perhaps not as strong as seen in Europe and other parts of the world. And again, this was a borderline significance. Importantly for kidney disease, the benefits were consistent across the eGFR bands that were seen and consistent across the albuminuria ranges. The group with high albuminuria were significant in their own right. The other group weren't, but we have to remember that there are fewer of them, so there's a very broad confidence interval. And so now moving on to cardiovascular benefits, there was a benefit for MACE, cardiovascular death, non-fatal MI or non-fatal stroke. And as you can see, that was driven by a reduction in cardiovascular death. There was also a reduction in all-cause mortality. This is in order of 20% with a hazard ratio of 0.8. This is unusual in a single trial. The SGLT2 inhibitors did not show benefits for all-cause mortality in a single trial, although they did overall. So with those very strong clinical benefits, let's turn and look at the intermediate outcomes. Albuminuria was reduced by about 1/3. HbA1c was reduced by 0.8%, and forgive me for using old metrics. Now this is, of course, an important reduction, but not a huge reduction. Similarly, weight was reduced by 4 kilos, and blood pressure was reduced by 2.2. Now, I'm calling these out because, as we spoke at the introduction, there's postulated direct and indirect systemic effects. These systemic effects, while important, don't seem sufficient to explain the profound clinical benefits. These were in a population with CKD. I'm showing you here the reductions in HbA1c and body weight for GLP-1 receptor agonists overall, and these are from the normal population. So you can see in the normal GFR population there tends to be a greater reduction in HbA1c and a greater reduction in body weight for the 1 milligram dose. That's in the orange bar there. And this is similar to the SGLT2 inhibitors, where we see these intermediate effects don't have as profound an effect as in the population with normal GFR. So I'd like to also turn to the Chinese population, and here we have some data from Sustain China that looked in people with normal GFR, looked at HbA1c and weight. Now, it's not a dedicated kidney disease trial, but it gives us a comparison. In these trials, they looked at the 0.5 milligram dose and the 1 milligram dose. So for the 1 milligram dose that we see in flow, the reduction in HbA1c was 0.8%, same result that we saw in flow, and for weight was 3.8 kilos. So from these intermediate results at least, it appears that the Chinese population has the same response as the overall populations. And I'd like to just now include oral semaglutide. To date, we've talked about flow, which was a subcut weekly injection. But as you know, the oral GLP-1 receptor agonists are being developed and are on their way. And in the longer term, you imagine that these might be more, will be at least as important in our therapeutic armamentarium. And so for these, again, in the Chinese population, we're seeing the same types of glucose and weight reduction that we see in the population overall. So now moving on to other endpoints, going back to flow. Flow reduced the loss of GFR, an important intermediate endpoint. You can see there's a little bit of a wobble at the beginning. Now we expect to see a reduction in, an acute reduction in eGFR with these agents that reduce intraglomerular pressure. But as well, we've got the confounder of the loss of body weight that you see with the GLP-1 receptor agonists. So the study also analysed cystatin-based eGFR, and that smoothed out the wobbles at the beginning, and you can see here a more clearer separation with a benefit, a stabilisation in GFR loss. So now my brief is not safety, but I wanted to just quickly speak about safety as an important endpoint. What we see overall is that there are fewer SAEs in people assigned to the GLP-1 receptor agonist than there were in people assigned to placebo, a reassuring message. But the SAEs that we did see were predominantly gastrointestinal, nausea, diarrhoea, vomiting and so forth. Now again, I'd like to just quickly refer back to the Chinese population. And you can see that the profile is similar, low rates overall of people who withdrew, but quite high rates of gastrointestinal effects overall, particularly of diarrhoea. Now, everyone who has dealt with these populations has found that it's beneficial to really be careful about titrating up, and so these might be some of the symptoms that you're looking for when you're titrating up to dose. So we'll now move quickly through the SGLT2 inhibitors because I think this audience is now very familiar with the wonderful evidence that we've got there. I'd like to just quickly reflect on the mechanisms, the postulated mechanisms of benefit for the kidney. And in the SGLT2s, these include the reduction in glomerular hyperfiltration, but there also appears to be less energy expenditure, and that might be a reason why we're seeing benefits for acute kidney injury. Those benefits were completely unexpected, but this may be why. And as well, we see reductions in some of the pro-inflammatory and pro-fibrotic markers. So now we have 13 large outcome trials in SGLT2 inhibitors, and that includes 90,000 participants randomised in these trials, of whom 75,000 had diabetes. And as we've seen earlier, the SGLT2s concordantly reduce CKD progression, and that's seen with similar effects in people with diabetes and without diabetes. In the diabetic population, there's a reduction of 38%, a hazard ratio of 0.62, quite profound. There are also benefits for particularly heart failure-based endpoints. So for cardiovascular death and hospitalised heart failure, there's a reduction with a hazard ratio of 0.77, so about a 1/4 reduction in heart failure events. And as well, the unexpected finding for acute kidney injury. Now that you would say was an exploratory analysis in any individual trial, but when we see consistent findings over these 13 trials, then that starts to look a very real finding. And again, we're seeing a reduction of almost a 1/4 in these events overall. With all these agents, we see an acute dip in eGFR, as we do for the GLP-1 receptor agonists, which is reversible when people are taken off in washout studies. But this acute dip in eGFR is then followed by stabilisation, so that the patient is benefiting overall. We saw the same patterns in Credence and in DAPA-CKD, and in both studies there was less of an acute dip in people with the lowest eGFRs. Now, presumably that's because they have fewer functioning nephrons to respond to the change in filtration pressure. But it's reassuring clinically when we're starting patients, because the people with low GFRs had the same clinical benefits for the hard endpoints. Another particular feature of the SGLT2 inhibitors that's important for a small population is that they appear to reduce gout, both uric acid and episodes of gout. And for some people, that's an important benefit. We also know that the effects of the SGLT2 inhibitors, those profound clinical benefits, are at least as present in the Asian population as the rest of the world. This is an analysis from the Credence population, in whom 15% of participants were from Southeast Asia. And I won't go through the individual endpoints, but you can see that numerically the effects were stronger in Asia. Statistically, there wasn't a difference, and you can see the overlap in the confidence intervals. But that gives us reassurance with an effect at least as strong of drugs that are very powerfully protective. What that means is that the number of patients needed to treat to prevent an event is even lower in Southeast Asian participants as elsewhere. So, for instance, to prevent one episode of progressive kidney failure, you only need to treat 13 patients. And so I'd now like to quickly finish up by talking about where this leaves us with the potential for combination treatment. We don't yet have large trials that test the effects of combination treatment. We do know from the SMART-C collaboration that the effects were, for the benefits for SGLT2 inhibitors were as strong in people who were treated with a GLP-1 receptor agonist as people who weren't. Now, there are only a few % of patients in that category, but at least that generates a hypothesis that the effects will be additive. We saw that for CKD progression, for heart failure hospitalisation, and for all-cause mortality. Do we have any evidence the other way? Well, we don't yet have enough large GLP-1 receptor agonists to be really confident. Flow did look at the subgroup of 15% who were already on SGLT2 inhibitors. The number was too small to really derive any statistical conclusions. The effect did not appear numerically as strong, but Flow was stopped early. And looking at the eGFR slopes, it may be that lower risk population just didn't have enough time. But it does mean that we do need definitive studies to answer that question of whether the effects are additive that way. So I'd like to also point out that both these drugs have been tested in people at high risk of kidney progression in the dedicated trials, largely in people with high levels of albuminuria. And the other thing I'd like to mention is the effect on body mass. Now, we're talking about people in these trials who were not people with morbidly obese conditions. Both the trials had people with an average starting weight of around 90 kilos. There is concern, people express that if there's a lot of weight loss, that some of that might be lean weight. Now, this trial looked at both, it was a smaller study, but it looked at both SGLT2 inhibitors and GLP-1 receptor agonists and showed that while people lost lean body mass, they lost more adipose tissue, so that the body ratio of lean mass to adipose was favourable. Now, I think that's really important, particularly as we're treating older patients, where it really becomes quite a concern if they might be losing lean mass. So I think that's reassuring for both agents. And then on the less positive side, we've heard a few speakers today talk about adherence and that these drugs will not work if people are not taking them. So this was a study we conducted from real-world evidence in Sweden, and I think that's important. Sweden has a very coordinated healthcare delivery with a universal payer, and so it would be an optimised health system, you would think. Even in Sweden, there's up to 35% of people had stopped taking their SGLT2, or up to 40% had stopped taking their GLP-1 receptor agonist at 12 months. What you also see there is compared with DPP-4 inhibitors, people on SGLT2 inhibitors and GLP-1 receptor agonists have pretty similar rates of non-persistence. You can see there the graphs over two years. Now, there's, slightly statistically, there's more people on the GLP-1s and SGLT2s drop out in the first year, less in the second year, but I think none of that really matters as much as the overall effect, the overall pattern, and that's that people on any of these drugs, second-line diabetes care, are dropping out at very high rates. And so I would reaffirm what everyone else has said today, that we now really need some implementation research on how we overcome these barriers, because no one's going to get a lifetime benefit if they're not getting lifetime treatment. So back to my topic question, the similarities and the differences. So there are some striking similarities in these big trials, and that's that the populations are very similar. Similar levels of high kidney risk in the dedicated kidney trials. And what we saw was benefits for both agents for the reduction of progressive kidney disease in diabetes and reductions in atherosclerotic cardiovascular events. We've also seen similar profile at the diabetes dosing we've been talking about, with relatively modest effects for HbA1c and weight. And the point of that is we shouldn't use HbA1c or weight to make decisions on whether the agent is working or not. We should trust in the large trials that show that the big clinical benefits come despite those intermediate markers. There are some differences, of course. There's much more evidence at the moment for the SGLT2 inhibitors who've come through from the development a little bit earlier. So far, we only have one large trial for GLP-1 receptor agonists, and that's in diabetes alone, but I think there will be more on the way. So far we have evidence of benefit for the SGLT2 inhibitors in diabetes, CKD and heart failure, and the GLP-1 receptor agonists at the moment in diabetes and obesity. SGLT2 inhibitors show all-cause mortality only in the combined trials, whereas Flow showed it in a single trial. SGLT2 inhibitors show profound benefits for heart failure. The GLP-1 receptor agonists didn't show that so in Flow that we've seen, although in people who are morbidly obese, in other trials, such as the SELECT trial, there is a benefit there. There have been some unexpected benefits, and this is a reason why we need to do large trials. We saw unexpected benefits for acute kidney injury for the SGLT2 inhibitors for things like uric acid and gout. And of course, the two agents have a different adverse event profile, and that might also be something that helps when you're prescribing to patients. Genital mycotic infections are increased with SGLT2 inhibitors, whereas gastrointestinal side effects are increased for the GLP-1 receptor agonists. So where do we go next? Well, I think the next path needs to be looking at ways to improve adherence and tolerability of these agents, and also to look at combination and what are the effective combinations, what's the effective dosing regime, particularly what's the way to start. There's been a lot of interest in the heart failure world in rapid sequence uptake. Is that going to be beneficial for our population? Or is the risk of small events of hyperkalemia, for instance, or changes in EGFR, will that change persistence in the longer term? So we have a very exciting future in front of us and a number of challenges to really turn around the growing burden of diabetic kidney disease. So thank you.
Thank you so much. Any questions or comments from the floor? Yes, Philip.
Thank you, Meg, for the excellent talk. I think what comes down, obviously, from your very last slide is that I think this question history has been asked many times. So I think probably in Hong Kong, I would like to sort of, once again, the audience listen to your voice as well. And how do we sort of implement the 3 drugs or even more in the future? I mean, obviously, one is in terms of the cost of providing this, the adherence to the drugs, and also which one is the first to use? And are we giving everyone all these bars for and then to do this? So this is probably the major future challenge to us.
Look, I think you're so right. I think we can be reasonably confident now that for people on SGLT2s, whether we'll get a benefit, whether or not they're on GLP-1. We haven't seen the reverse yet. I think it does need to be proven that you do get additive benefits if you're already on an SGLT2 inhibitor. But I think the more important question is how we titrate up safely but quickly. We know from the RAS days, when we only had one drug that worked, RAS inhibitors, that a single episode of hyperkalemia meant that half of patients would be taken off or reduce their dose of RAS and would not be recommenced. And that was when there was no other option. So again, I don't think we can assume that just starting them all quickly will be effective. It may be, but it may be that small episodes like hyperkalemia will rattle clinicians and patients, and that we need a more moderated course. One thing we do know from the STRONG-HF trial was that they had better uptake, but they also needed more visits to do it. So I think that's another reason we need trial evidence to show if more visits early on helps improve uptake, then that's an argument for funders to pay for that activity, because these agents clearly are cost-effective in the longer term. Anything that prevents dialysis admissions is going to be cost-effective.
Thank you.
Any more questions? All right, thank you. Let's move on to the next speaker.
It is my pleasure to introduce the last speaker, Professor Connie Rhee. Professor Connie Rhee is a professor of medicine at David Govan School of Medicine at UCLA and chief of nephrology at the Veterans Affairs Greater Los Angeles Healthcare System. Professor Rhee completed her medical school training at the Northwestern University Feinberg School of Medicine and her residency and chief residency at the Oregon Health and Science University. Professor Rhee subsequently pursued her clinical nephrology fellowship and postdoctorate research training at the combined Brigham and Women's Hospital, Massachusetts General Hospital Nephrology Fellowship Program, and she also completed her Master of Science in Epidemiology degree program at the Harvard School of Public Health. Professor Rhee currently serves as the editor-in-chief of CJASN. She also leads a robust research program centered on the intersection of kidney disease, nutrition, and endocrinology metabolism that has been supported by the multiple NIH, National Kidney Foundation, and American Thyroid Association grants, in which she has served as a principal investigator. She also mentored a wide cadre trainees in the areas of nephrology, nutrition science, endocrinology, metabolism, public health, biostatistics, and related discipline. Welcome, Professor Rhee.
Okay.
Well, thank you, Dr. Wong and Dr. Yang, for your very kind introduction. I would like to thank the ICCN and the Hong Kong Society of Nephrology for their hospitality and for the opportunity to present to you today. And as mentioned, I'll be speaking to you on the topic of the ADA-KDIGO consensus report on diabetes management in CKD, more alike than different. These are my disclosures. Let's see. Okay. Over the next 25 minutes, there are three main areas I want to cover. We are first going to review the scope of diabetes in CKD and end-stage kidney disease. We are then going to examine the ADA and KDIGO consensus statements for CKD and diabetes. And then we'll close with discussing the practical implementation of the ADA-KDIGO consensus statements and supportive evidence. So in 2001 to 2022, I had the honor of participating in a consensus report writing committee that was convened by the ADA and KDIGO, in which we were tasked with drafting consensus statements based on the guidelines in order to inform the clinical management of patients with CKD and diabetes. In this writing committee that was led by the late George Bacchus and also Ian DeBeer, and that was also comprised of nephrologists, primary care providers, pharmacologists, and patients, we were given the responsibility of reviewing the guidelines, supportive evidence, and developing consensus statements in which there was alignment between the guidelines and that were also grounded in high-quality clinical trial evidence. Now, in terms of the rationale for this consensus report, as we know, there is an increase in global burden of diabetes such that there are currently nearly 540 million adults living with this endocrine disorder across the world. And by 2045, we anticipate that there will be nearly 800 million adults with this condition. And roughly, there are 75% of adults with diabetes living in low-income and middle-income countries. It's also well known that there is a very strong interaction between diabetes and kidney disease, such that we see that CKD is one of the most prevalent complications of diabetes, affecting 30 to 40% of type 1 and type 2 diabetics. In turn, diabetic kidney disease is the leading cause of end-stage kidney disease, such that Brunei, parts of Mexico, Singapore, and Hong Kong have the highest proportion of de novo patients with incident ESKD due to diabetes. We also know from USRDS and global data that we see the fastest rising rates of de novo ESKD due to diabetes in parts of Asia as well as in the United States. And this bears tremendous clinical importance given that we know that patients with ESKD due to diabetes have a much worse survival compared to their non-diabetic counterparts, largely due to cardiovascular causes. And as we've heard earlier today, last fall, the American Heart Association published a presidential advisory discussing the cardio-metabolic syndrome, also emphasizing the importance of a multidisciplinary approach in terms of mitigating this high cardio-metabolic risk in diabetic kidney disease that was also endorsed by our consensus report. And therefore, I'm going to be taking you through some highlights of our consensus report in which we had consensus statements that were largely categorized in 4 areas, including screening and diagnosis, the role of comprehensive care, glycemic control, as well as the pillars of pharmacotherapy used to reduce this cardio-kidney metabolic risk. Now, starting with screening and early diagnosis, in the US and other countries, there is a very low awareness of CKD. For example, in the US, there are nearly 36 million people with underlying CKD, among whom the vast majority remain unaware of their condition. Recognizing this, in 2019, the US government launched the Advancing American Kidney Health Initiative, which prioritized the importance of early identification of at-risk patients with CKD, as well as those with early disease, emphasizing the importance of primary and secondary prevention of CKD. Although we did not have a specific consensus statement in regards to early screening and diagnosis, we did emphasize that the ADA and KDIGO both recommend annual screening for CKD. That should start 5 years after the diagnosis of type 1 diabetes and at the time of diagnosis with type 2 diabetes. And similar to the ASN and National Kidney Foundation, screening should be comprised of eGFR based on a non-race-based CKD-EPI formula with or without cystatin C, as well as with spot UACR. And although this is not per se grounded in evidence, there was opinion that the frequency of screening should depend on underlying risk classified by the KDIGO heat map according to higher levels of UACR as well as declining levels of eGFR. Now, moving to comprehensive care, both ADA and KDIGO have underscored the critical role of a multidisciplinary comprehensive approach in the management of diabetic kidney disease. And we drafted a consensus statement indicating that in both patients with diabetes and CKD, they should be treated with a comprehensive plan that is agreed upon by their healthcare professionals and patients, that is grounded with a foundation of optimizing nutrition, exercise, smoking cessation, and weight control, with the add-on of evidence-based pharmacologic interventions that are aimed at preserving end organ function, with other therapies used to achieve targets for glycemia, lipids, and blood pressure. ADA and KDIGO have also emphasized the importance of medical nutrition therapy and access to specialty-trained dietitians and nutritionists. Both guidelines have supported the role of individualized and balanced medical nutrition therapy with greater intake of fruits and vegetables, whole grains, and lower intake of sodium, refined carbohydrates, as well as sugar-sweetened beverages. Where there have been some nuanced differences are recommendations regarding dietary protein intake across various kidney health guidelines. So whereas both KDIGO and ADA have recommended a moderately low dietary protein intake of 0.8 grams per kilo per day, in our consensus report, we did acknowledge that the National Kidney Foundation and Academy of Nutrition of Dietetics KDOQI guidelines have actually recommended a slightly lower dietary protein intake threshold in patients with CKD and diabetes who are metabolically stable, which have also been endorsed by the International Society of Renal Nutrition Metabolism. But it bears mention that the most recently updated KDIGO guidelines in CKD published earlier this year, while recommending a dietary protein intake of 0.8 grams per kilo per day, have also issued a practice point supporting that in some adults with CKD who are willing and able, a very low protein diet intake of 0.3 to 0.4 grams per kilo per day, if taken in conjunction with essential amino acids and keto acid analogs. And the upcoming ADA standards of care have also emphasized the importance of plant-based sources of protein. I do want to underscore, however, that the updated NKF-KDOQI guidelines that were published in 2022 have indicated that while for non-diabetic stage 3 to 5 CKD patients who are metabolically stable, there is grade 1A evidence based on clinical trials for lower protein diets in terms of reducing the risk of ESKD and death, for patients with diabetes and CKD, their recommendations for lower dietary protein intake is currently based on opinion-level evidence. But in terms of physiologic rationale, there is premise for these recommendations. So while we see with higher dietary protein intake, dilation of afferent arterioles, glomerular hypofiltration, and increased intraglomerular pressure, with lower dietary protein intake, we see afferent arterial vasoconstriction, a reduction in glomerular hypofiltration, a lowering of intraglomerular pressure, as well as decreased proteinuria. Now, as just mentioned, the ADA has emphasized the importance of not just the amount, but also the source of dietary protein intake. So what do the current guidelines say about plant-based diets? Well, the most recent KDIGO-CKD guidelines have issued a practice point also emphasizing the importance of plant-based foods as opposed to animal-based foods, whereas in KDOQI, based on the 2020 guidelines, had indicated that at the current time, there are not enough clinical trials yet informing the source of plant versus animal-based proteins in the CKD population. But I did want to share that we are currently conducting an NIH multi-center clinical trial of plant-focused nutrition in patients with diabetes with CKD, in which we are randomizing patients to a plant-based low-protein diet versus a non-plant-based low-protein diet, looking at measures of dietary adherence, nutritional and body composition measures, glycemic safety and kidney endpoints, as well as patient-reported outcomes that I hope can inform future iterations of guidelines in this area. Now moving to glycemic control, even in the absence of diabetes, patients with CKD are vulnerable to dysglycemia via multiple pathways. And our and others' research have uncovered a very high burden of hypoglycemia that is associated with higher death risk in the diabetic kidney disease population, presumably via both central nervous system as well as underlying cardiovascular pathways. And there has remained debate, what is the optimal glycemic target in terms of advanced diabetic kidney disease patients, including those receiving dialysis? Now, both the ADA and KDIGO guidelines endorse bi-yearly A1C assessment in patients with type 2 diabetes who are stable, who are achieving their glycemic targets, as well as quarterly assessment in patients who are not achieving targets, who are on intensive therapy, or who have also undergone a therapy change. But while the KDIGO 2022 diabetes guidelines have recommended an A1C target of 6.5% to 8% in patients with non-dialysis dependent CKD with diabetes, they advise that these targets do not pertain to patients on dialysis and that the accuracy and precision of A1C declines with lower levels of eGFR. And with respect to the ADA guidelines, while an A1C of less than 7% is recommended in patients who are non-pregnant, who do not have severe or frequent hypoglycemia, they also support less stringent glycemic targets in patients with lower life expectancy, as well as those in whom the harms of treatment may outweigh the benefits. So recognizing the limitations of the accuracy and precision of A1C, particularly in the lower levels of eGFR of diabetic kidney disease patients, the ADA and KDIGO guidelines and our consensus report do support the use of concurrent A1C, CGM, particularly in patients who are susceptible to hypoglycemia in whom we do not know if A1C is accurate, as well as self-monitored blood glucose, particularly if patients are on insulin therapy. For those of you who have not yet had experience with CGM, as many of you may know, this is a convenient, automated, less invasive tool for comprehensive glycemic monitoring, which is made up of a small subcutaneous device that can be applied to the abdomen or to the arm, and it measures glucose enzymatically via the interstitium, and with some of the more contemporary devices can provide real-time glucose measurements as frequently as every 5 minutes to a receiver or to a smartphone. And as we heard earlier from Dr. Chan and others, it provides an array of metrics, including time at target range, above and below range, as well as very patient-friendly alerts that can warn of impending hypo and hyperglycemia. Now, unfortunately, in the United States, most of the commonly used CGM devices are not yet FDA approved in dialysis patients. And part of the concern is related to the accuracy and precision of CGM in this population. So I have been a huge fan of work by Dr. Chan and others in terms of their work of CGM in the PD population. And our group recently published an analysis looking at hemodialysis patients with diabetes who were hospitalized during the pandemic period who went concurrent CGM and blood glucose measurement, in which we looked at agreement and correlation between these metrics. And while we did see some mild bias when looking at Bland-Altman analysis, we overall saw strong correlation between CGM and blood glucose that was a little bit attenuated during the hemodialysis period. And using consensus error grid analysis, which is a method that endocrinologists use to assess the clinical safety as well as accuracy of CGM measurement, we saw that nearly all CGM values were in the clinically acceptable zones. Another motivating reason for using CGM is also its potential impact on patients' quality of life. So this was a case report published by one of our postdoctoral research fellows, Dr. Yoko Narasaki from Tokushima, Japan, in which she described the experience of one of our young Latin American patients in the US who is legally blind, who could not comply with self-monitored blood glucose. And because of his PCP and endocrinologist who advocated for him getting a CGM device, he was able to better control his A1C from a 12 to 14% range, later to a 6 to 7% range, and had much fewer events of hypo and hyperglycemia. Most importantly, our patient had indicated to us that not only did the device allow for better adherence to his diabetes regimen, it also led to less lifestyle interruption, less hypoglycemia fear, as well as better quality of life. So motivated by this and our patient's experience, we applied for government funding, and we're very grateful to the NIH who awarded us with a multi-center NIH R01 grant to pursue a clinical trial that is active now, in which we're randomizing hemodialysis patients with diabetes to CGM versus usual care, and looking at the effects upon glycemic control, as well as patient-reported outcomes that we hope can in the future improve access to CGM amongst dialysis patients in the United States. Now moving to the pillars of pharmacotherapy that reduce cardio-metabolic risk. As we heard from expert speakers on the symposium, one of the foundations of these pillars of therapy is RAS inhibition, and as we know, there have been a number of clinical trials showing the benefits of RAS inhibition in type 1 and type 2 diabetes in terms of kidney health outcomes via modulation of efferent arterial vasoconstriction, leading to lowering of glomerular hypofiltration and hypertension as major risk factors for incident CKD and CKD progression. Now, while there are some nuanced differences in terms of the target blood pressure goals across the ADA and KDIGO guidelines, in our consensus report, we discussed that an ACE or an ARB is recommended for patients with type 1 and type 2 diabetes who have hypertension as well as albuminuria that are titrated to the maximum tolerated dose with respect to these agents. Now, in terms of the next pillars of therapy, these pertain to the glucose-lowering agents, including the older and newer anti-glycemic agents, including the metformin, biguanides, SGLT2 inhibitors, and GLP-1 receptor agonists. And we had several consensus statements with regards to these medications, recommending that both metformin as well as SGLT2 inhibitors be considered first-line therapy in patients with an eGFR greater than or equal to 30 or greater than or equal to 20 respectively, and that GLP-1 receptor agonists be utilized as second-line therapy in patients who did not achieve glycemic targets with metformin or SGLT2 inhibitors. And I will not go into detail since we already heard a wonderful overview of the physiology from Dr. Jardine just a while ago. But we know that the benefits of SGLT2 inhibitors in terms of mitigating this cardio-metabolic risk extend beyond that of glycemic control. And in contrast to RAS inhibition, which only acts upon the efferent arteriole, we have the benefit of SGLT2 inhibitors also modulating this afferent arterial vasoconstriction, further reducing this glomerular hypofiltration and this glomerular hypertension. Now, based on a number of clinical trials that were conducted early on looking at the benefits of SGLT2 inhibitors on exploratory kidney outcomes in the non-CKD population, this led to a series of very exciting clinical trials we already heard about from Dr. Jardine, including Credence, DAPA-CKD, and PA-KIDNEY, that showed benefits of SGLT2 inhibitors on kidney composite endpoints in both patients with and without diabetes, with an eGFR as low as 20. And although early on there was some trepidation about potential side effects seen in the parent trials in our particularly vulnerable and frail CKD populations, we have seen a differential side effect profile, also I think mentioned by Dr. Jardine, and which I'll talk a little bit about in just a bit in terms of real-world data. Now moving to our next pillar of therapy, GLP-1 receptor agonists. As we heard earlier, these agents act by following the ingestion of food, leading to release of incretins and modulating glucagon release from the alpha cells and insulin release from beta cells, and also affecting appetite as well as gastric emptying, leading to improvements in metabolic status as well as obesity. The FLOW trial, which randomized over 3,500 patients with type 2 diabetes and the eGFR as low as 50, as we heard earlier, was stopped earlier because of overwhelming efficacy seen in the intervention arm with respect to the kidney composite endpoint, and including a secondary endpoint related to all-cause mortality. Therefore, this also remains a cornerstone among our pillars of therapy for cardio-kidney metabolic risk. Now moving to the non-steroidal MRAs, we learned from our cardiology colleagues about the benefits of these agents in terms of reducing cardiovascular risk, but we are concerned about potential side effects in the kidney population, particularly hyperkalemia and decline in eGFR. Therefore, there has been growing interest in the role of non-steroidal MRAs that have greater affinity to the mineralocorticoid receptor. And we also added a consensus statement based on clinical trial data about the role of non-steroidal MRAs, recommending their use in patients as second-line therapy for type 2 diabetes among those with an eGFR as low as 25 with normal serum potassium levels and a UACR of greater than or equal to 30. And this was largely based on the Fidelio-DKD trial led by Dr. Bakris, among others, which, as you remember, was a double-blind placebo-controlled clinical trial randomizing patients to finerenone versus placebo among those with type 2 diabetes and albuminuria CKD with a maximally tolerated dose of an ACE or an ARB, looking at a primary composite kidney endpoint of kidney failure, decline in eGFR, or renal cause of death. And we saw a potent benefit in the finerenone arm with respect to placebo in this kidney composite endpoint. Although the frequency of adverse events did not differ between the two arms, there was a greater proportion of patients in the finerenone group who did experience a hyperkalemia associated with a discontinuation of their regimen in this clinical trial. Now, moving to the last pillar of therapy includes the statins. So both the ADA and KDIGO have supported the use of statins for primary and secondary prevention. And so we included a consensus statement in the report indicating that statins are recommended for all patients with diabetes and CKD. And with respect to dose, moderate intensity is recommended for patients for primary prevention of atherosclerotic cardiovascular disease, and high intensity among patients with existing disease as secondary prevention, as well as among those with some high-risk atherosclerotic cardiovascular indicators. So in summary, we now have in our armamentarium a multitude of pillars of therapy that we can use that can mitigate this cardio-kidney metabolic risk, and how do we put this together? So in our consensus report, we published this algorithm of which at the foundation are lifestyle interventions, including a healthy diet, physical activity, smoking cessation, as well as weight management. And at the time of publishing this consensus report, which was pre-flow, we had recommended as first-line therapy SGLT2 inhibitors as well as metformin for glycemic control, RAS inhibition for hypertension control, and statins for lipid control. But if glycemic targets are not achieved, to add GLP-1 receptor agonists as second-line agents, as well as non-steroidal MRAs for better blood pressure control. In our report, we had a table that was created by one of our pharmacology colleagues, Dr. Josh Newmiller, which also discussed considerations of pharmacotherapy selection based on clinical factors and other considerations in these patients. But as we discussed earlier, there's a lot of ongoing uncertainty. What is the sequence of adding these drugs, and what is the timing that we hope future studies will inform in the next iteration of consensus reports and guidelines? Now, in my geographic catchment, despite SGLT2 inhibitors being recommended as first-line therapy, and as we've seen in global data, we still see very poor uptake of these medications for various reasons. Some relate to access, education, but I also believe that concern about the side effect profile has also led to lesser utilization of these medications. So this was a recent real-world analysis that we published looking at the comparative effectiveness of SGLT2 inhibitors, DPP-4 inhibitors, and GLP-1 receptor agonists in a large national veterans population using the VA database. And compared with DPP-4 inhibitors, we found that SGLT2 inhibitors had actually a lower risk of infection-related hospitalization, no higher risk of GU infection or amputation, but actually a higher risk of euglycemic DKA. So I found it critically important, as also endorsed in our consensus report, about the role of multidisciplinary collaboration with endocrinologists, primary care cardiologists, in terms of monitoring and adherence, as well as mitigating the safety risk of these medications. And I want to end with also adding that compared with conventional agents, our newer anti-glycemic therapies also have a lesser hypoglycemia risk, as also recommended by KDIGO. And this is particularly important when we consider about the disproportionately high burden of hypoglycemia that we see in our advanced diabetic kidney disease population. So in conclusion, a multidisciplinary strategy is needed to mitigate the cardiovascular kidney metabolic complications of diabetic kidney disease, and lifestyle modifications, including nutrition, exercise, and risk factor modification, are the foundation of evidence-based pharmacotherapies. CKD and ESKD patients are at risk for dysglycemia via multiple pathways, and adequate glycemic monitoring with hemoglobin A1C, CGM, and self-monitorable blood glucose are a cornerstone in their management. SGLT2 inhibitors reduce cardiorenal risk independent of their effects on glycemic, blood pressure, and lipid control. And we should consider SGLT2 inhibitors and metformin as first-line therapy in appropriately selected patients, as well as RAS inhibition and statins. And finally, GLP-1 receptor agonists and non-steroidal MRAs had demonstrated efficacy in clinical trials in reducing cardio-kidney metabolic risk in type 2 diabetes patients with CKD. Currently, these are recommended as second-line therapy in our ADA-KDIGO consensus report, although we look forward to more clinical trials in this area, further informing clinical practice. I once again want to thank the ICCN, the Hong Kong Society of Nephrology, ADA-KDIGO, the Consensus Report Writing Committee, and many collaborators, and the NIH for their support of our research of the years, and I'd be happy to take any questions.
Okay, thank you. Any question from the floor? Okay. Professor Jardine?
Hi, John here from Mount Sinai, New York. Connie, congratulations. Really nice summary. So my question is about the protein diet. So I mean, we suggest 0.8, even lower. But now, you know, the hypothesis is that the high protein diet can cause glomerular hyperfiltration. Now we have all this wonderful drug, SGLT2, or the drug. I may worry less about that. And we also deal with many patients with proteinuria. So we always worry to give such low protein diet for patients. So I just want to ask your thought about that. Thank you.
Yeah, that's a great question. So the question was in regards to, I guess, the efficacy, the safety of low-protein diets, particularly in the context of these very potent pharmacotherapies we see in the setting of diabetic kidneys and also even in CKD without diabetes. As you saw in our consensus report, at the foundation is lifestyle, and there is actually some emerging secondary analyses of clinical trial data showing the synergistic effects of SGLT2 inhibitors with low-protein diet. Hope to see more also with GLP-1 receptor agonists. However, what we lack in the diabetic kidney disease space are rigorous clinical trial data. Based on National Kidney Foundation KDIGO guidelines, there is grade 1A evidence in non-diabetic stage 3 to 5 CKD patients who are metabolically stable, so those who do not have protein energy wasting, who are at risk for malnutrition in terms of lowering the risk of ESKD and death based on grade 1A evidence, but we don't have that kind of data in diabetic kidney disease right now. So we have one active multi-center NIH R1 trial that we're conducting at this time. We hope that others in the global community will also pursue this research so we can better inform clinical practice in this area. So that's a great question. Thank you.
Professor Jardine?
Thank you, Connie. That was a fabulous talk, a really good overview. You nicely outlined how the cardiovascular outcome trials that the regulators require revealed all these benefits for SGLT2 inhibitors. If we hadn't had them, it would be a sort of third-line mild glycemic control agent. But instead, we know that it has profound clinical benefits, and we're seeing the same with GLP-1 receptor agonists. So, given that, can you speculate on the logic of whether it's sensible to say that you'd add a GLP-1 receptor agonist if glucose targets aren't being met? Haven't we got beyond that?
I think this is an ongoing area of debate, and I think in my own experience collaborating with endocrinologists, it is still a lot of uncertainty and art in many ways. I would say that every diabetic kidney disease patient that enters my clinical office, I actually send them all to endocrinology so that we can co-manage the patients. And oftentimes I referred them specifically for SGLT2 inhibitor, and they come back on a GLP-1 receptor agonist. And many times actually, before the full trial data, I was actually quite frustrated, not understanding why we wouldn't put the patients on first-line therapy, at least from a kidney perspective. But in terms of endocrinology's perspective, I completely understand in terms of its kind of all-encompassing benefits in terms of weight loss, glucose control, now seeing kidney benefits. So I think a lot of it is also driven by patient choice, their tolerability of the agents in terms of the side effect profile. So I think in real-world clinical practice, I still see it as an art, but we need clinical trials, real-world longitudinal data to really see how do we add these therapies together, as you previously highlighted, and what is the timing of these medications. So
I totally agree with that. It's only the clinician in front of the patient who can work out with the patient what's most appropriate. What I meant though was the guideline advice that if the patient's already on an SGLT2, you consider the GLP-1 only if glycemic targets haven't been met. Like, shouldn't the rationale for adding a GLP-1 be more on the clinical endpoints rather than HbA1c?
Yeah, and I think notably these were formulated in the period of 2001 to 2022, well before we knew the forthcoming evidence from the FLOW trial data. Although I would say, I can't speak for what is coming down the pike, but in speaking with KDIGO, I believe that at this time, many of the staff and leaders are indicating that still GLP-1 receptor agonists are being recommended as second-line therapy, although there are some reports coming out by experts in the field, opinion leaders, I think speaking more to this rationale and recommendations which we look forward to. So thank you for the great question and great point.
Okay, I think we all agree that we have very beautiful and wonderful talks delivered by the three distinguished speakers. So I think it's time for us to draw the section closed. Thank you very much for your attention.